Welcome to OET Answers.
Occupational English Test. OET Answers Practice Test, Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for Extract 1. You hear a GP talking to a patient about a rash and other symptoms. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Alex. How are you feeling today?
Not too great, to be honest. I've been feeling pretty run down lately.
I see. And I notice you've booked the appointment due to a rash that's developed. Could you tell me a bit more about it?
Yes. The rash appeared about 2 days ago. It started around my neck and has spread to my arms and chest. I've also had a fever on and off for the past few days, which got me really worried.
I understand. Have you noticed any other symptoms besides the rash and fever?
Well, I've had a really sore throat and some coughing, but it's the rash that concerns me the most. I've never had anything like this before.
How about your eyes? Have you had any irritation or sensitivity to light?
Actually, yes. My eyes have been itchy and kind of watery, and bright lights have been bothering me a lot more than usual. Actually,
That's helpful to know. It sounds like you might be dealing with measles, especially given the combination of symptoms like the rash, fever, cough, sore throat, and eye irritation.
measles? I thought I got vaccinated for that when I was a kid.
Yes, most people receive the MMR vaccine, which protects against measles, mumps, and rubella. However, sometimes the vaccine's immunity can weaken over time, or in rare cases, the vaccine may not be fully effective. Have you traveled recently or been around anyone who has been sick?
I haven't traveled, but I work in a daycare, so I'm around kids a lot. I heard that one of the children came down with a bad rash last week, but I didn't think much of it at the time.
That could be a possible source. Measles is highly contagious, and outbreaks can happen, especially in places like daycares or schools where people are in close contact. The incubation period, the time between exposure and the onset of symptoms, can be up to 2 weeks, so it's possible that's where you picked it up.
Wow, I didn't realize it was that contagious. So what happens now?
First, we'll need to confirm the diagnosis. I'll order a blood test to check for the measles virus or antibodies, and we can also take a swab of your throat to check for viral RNA. If it's confirmed to be measles, you'll need to isolate yourself to prevent spreading it to others. Measles can be quite serious, especially for young children, pregnant women, and people with weakened immune systems.
Is there anything I can do to feel better in the meantime?
The best thing you can do right now is rest, stay hydrated, and manage your fever. Paracetamol or ibuprofen can help reduce the fever and discomfort. For the eye irritation, try to avoid bright lights and rest your eyes when possible. Unfortunately, since measles is caused by a virus, there isn't a specific treatment to cure it. But your body should be able to fight it off on its own. Symptoms usually last about a week or so after the rash appears.
And should I be worried about any complications?
For most people, measles resolves on its own without causing long-term problems, but complications can occur, especially in adults. You might develop a secondary infection like an ear infection or even pneumonia. In rare cases, encephalitis, which is inflammation of the brain, can develop, but that's uncommon. Keeping an eye on your symptoms and seeking medical help if they worsen is important. I'll also want you to monitor for any signs of difficulty breathing, severe headaches, or confusion.
That sounds a bit scary.
I understand it can be concerning, but the majority of people recover fully without complications. The key is to take care of yourself, rest, and avoid spreading the virus to others. Do you live with anyone who might be at higher risk, like children or anyone with a weakened immune system?
Yes, I have a younger sister who's 6. She hasn't had her second MMR shot.
In that case, it's very important to limit contact with her until you're no longer contagious. We'll also want to ensure she gets vaccinated as soon as possible, if she hasn't already. Measles can spread easily through coughing and sneezing, so good hygiene and isolation are crucial. We'll talk more about what steps you can take to protect her.
Okay, that makes sense. How long will I be contagious for? Okay.
You're considered contagious from about 4 days before the rash appears until about 4 days after it shows up. So, until your rash has cleared, it's best to avoid contact with others. We'll also discuss notifying the daycare about your situation to make sure they can take proper precautions to prevent further spread.
Got it. I'll let them know once I have the test results.
Extract 2, questions 13 to 24. You hear a doctor talking to a patient called Mrs. Perry. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Welcome, Mrs. Perry. How are you today?
Hi, Doctor. Well, not great, to be honest. I've been dealing with some things that are starting to really worry me.
I'm sorry to hear that. Can you tell me what's been going on?
It's hard to describe, but over the past few months I've noticed that my skin has been tightening, especially on my hands. It's not just dryness or anything like that. It feels like my skin is pulling, making it harder to move my fingers. I also have these red spots, and sometimes my fingers go numb when I'm cold. I'm not sure if they're related, but it's been happening more often.
I see. Tightening of the skin and changes in sensation, particularly in response to the cold, can sometimes indicate an underlying condition. How long have you been noticing these symptoms?
The skin thing started maybe 6 months ago, but the numbness has been on and off for about a year now. At first it wasn't a big deal, just a little discomfort, but lately it's gotten worse. It feels like my skin is becoming too tight for my hands, and it's affecting how I do everyday things. Even holding a cup of tea can be tricky.
That does sound concerning. Have you noticed any changes in other parts of your body, or is it mainly your hands?
Mostly my hands, but I've noticed my face feels a little tight too, especially around my mouth. It's strange, and sometimes it feels like I can't fully stretch my lips. I haven't thought too much about it until recently because it's subtle, but now it seems like it's spreading.
And what about any other symptoms? Pain in your joints, heartburn, or perhaps difficulty swallowing?
Funny you mention that. I've had more heartburn lately, but I didn't think it was connected. I've also felt like food gets stuck sometimes when I swallow, especially if I'm eating something like bread. It's been happening more in the past couple of months. And yes, my joints are stiff, mostly in the mornings. I just figured it was part of getting older, but now I'm not so sure.
It's good that you've come in to talk about this. The symptoms you're describing, skin tightening, numbness, joint stiffness, and difficulty swallowing, can be linked to a condition known as scleroderma. It's a rare autoimmune disease that affects the connective tissue in your body, which can lead to the hardening and tightening of the skin. It can also impact other internal organs, including the esophagus, which may explain the heartburn and swallowing issues you've been having.
Scleroderma? I've never heard of it before. Is it serious?
It can be, but it affects everyone differently. Some people have only mild symptoms that don't get worse over time, while others may experience more significant issues depending on which parts of the body are affected. The good news is that there are treatments that can help manage the symptoms, though there's no cure for the condition itself. The key is early intervention and monitoring to prevent complications. It can be, but
That's a bit of a relief, but also a little scary. What causes it?
Scleroderma is an autoimmune condition, meaning your immune system mistakenly attacks your body's own tissues. In this case, it targets the connective tissues, causing excess collagen to build up. Collagen is the protein that helps keep skin firm, but when there's too much, it leads to that tight feeling you're experiencing. Unfortunately, we don't fully understand why it happens, though genetics and environmental factors may play a role.
I see. Is there anything I could have done to prevent this?
No, there's nothing you've done to cause this. Autoimmune diseases often come on without a clear trigger. What's important now is to focus on managing the symptoms and preventing any further complications. It sounds like the skin and joints are affecting you the most right now. Are you able to manage your daily activities, or is this starting to impact your quality of life?
It's definitely making things harder. I have to take longer to get ready in the morning because my fingers don't move as easily. And when I'm in the cold, my fingers go numb quickly. I've even noticed a few ulcers on my fingertips that seem to take forever to heal. I love gardening, but lately I've had to cut back because of the pain and the tightness in my hands.
That must be frustrating. The cold sensitivity and ulcers you mentioned are likely related to something called Raynaud's phenomenon, which is common in people with scleroderma. It causes the blood vessels in your fingers and toes to constrict in response to cold or stress, which is why your fingers turn numb or change color. There are medications that can help improve blood flow and reduce the frequency of those episodes.
That would be helpful. I'm always worried about my fingers now whenever I go outside. It's not like before.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear 2 medical professionals' discussion. Now read the question.
Have you heard about the new focus on nutrition and lifestyle advice in our dental practice guidelines?
Yes, I was just discussing it with another colleague. It seems to cover a lot of ground. There's advice on healthy eating, managing stress, and general lifestyle changes.
Yes, I suppose that's true, and I think it places a lot of emphasis on the nutrition part, don't you?
I'm not sure. I mean, yes, there's a significant amount of content about nutrition, but it makes sense. We're not just dealing with teeth. We have to think about the whole body's impact on oral health. Things like diet and lifestyle are directly linked to problems like cavities and gum disease, so it's important to address them thoroughly.
That's true, but I wonder if the balance is right. It just feels like a lot for us to manage alongside everything else.
Now look at question 26. You hear a medical professional explaining about blood-borne pathogens. Now read the question. While many of you have previously completed this training, it's important that we revisit it, especially now. The first part is ensuring that all staff are adhering to the standard precautions, including the proper use of personal protective equipment like gloves, gowns, masks, and face shields when dealing with blood or body fluids. Be sure to familiarize yourself with these protocols after this meeting. Also, Remember to safely handle and dispose of sharp objects to minimize accidental exposure. Finally, if an exposure occurs, ensure you follow the post-exposure protocols, which include immediate washing of the area, reporting the incident, and receiving appropriate post-exposure treatment as guided by the department. Are there any questions? Now look at question 27. You hear a trainer giving training session. Now read the question.
Hello everyone and welcome to this training on managing, documenting, and responding to adverse drug reactions. First, let's take a look at the main objectives of this course. By the end of the course, you will be able to identify adverse reactions from medications and document them accurately in patient records. Additionally, you will learn how to set up a system for reporting these reactions both within your organization and to external regulatory bodies. Next, we will work through case studies so that you will be able to demonstrate how to respond to adverse reactions in real-life clinical settings and ensure patient safety. We will also cover how to distinguish mild from severe reactions and provide appropriate responses. Our final set of objectives focuses on how to implement long-term monitoring to prevent future adverse drug reactions.
Now look at question 28. You hear two healthcare professionals discussing a training session on supporting patients with eating disorders. Now read the question.
It seems that only about 35% of the staff have completed the training on how to support patients with anorexia and bulimia so far.
Less than half, but it's crucial that everyone completes the training by the end of next week. Should we send out another email reminder?
We've already sent 2 email reminders, and I personally spoke to some team members about it. I think we should bring it up in the staff briefing on Monday morning.
That's a good idea. Will everyone be able to attend?
They should, but if anyone isn't available, we can discuss it with them directly one-on-one.
Now look at question 29. You hear a trainee doctor talking to a senior doctor. Now read the question.
Dr. Smith, may I ask you a question about the antibiotic choice for this patient with suspected bacterial pneumonia?
Of course. What do we know about the case?
The patient is presenting with a cough, fever, and shortness of breath. Based on the symptoms and history, I suspect it could be community-acquired pneumonia. I was reviewing different antibiotics and noticed there are many options available. I'm wondering which one is most appropriate in this scenario.
Good question. The key here is to first consider the likely pathogen. For community-acquired pneumonia in an otherwise healthy adult, Streptococcus pneumoniae is the most common bacterial cause, but we also have to consider other pathogens like Mycoplasma pneumoniae. So, typically, we would start with a broad-spectrum antibiotic, such as amoxicillin or a macrolide like azithromycin, especially if we are unsure about the specific pathogen. The choice will narrow as we gather more data, including sputum cultures, to target the specific bacteria.
So the initial antibiotic choice is broad spectrum to cover common pathogens?
Exactly. And once we identify the pathogen more definitively, we can adjust the treatment to be more specific.
Now look at question 30. You hear 2 hospital managers talking about a recent training session for volunteers. Now read the question.
Training activities went.
Well, we had a decent turnout, which was good. We asked a lot from the volunteers. On top of their usual tasks of helping out patients, they had to come up with solutions to case studies and participate in the group discussions.
Yes, that clinic approach we tried, where they solved real-life volunteer scenarios, seemed to keep everyone engaged. I'm just not sure if we focused enough on practical skills. Things like how to handle patient confidentiality or time management. Maybe we leaned too heavily on the creative side of things.
I see what you mean. That's something we should reconsider before we plan the next training session.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For question 31 to 42nd, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Extract 1. Questions 31 to 36. You hear an interview with Dr. Alice Thompson giving a detailed presentation on traumatic brain injuries. You now have 90 seconds to read questions.
I'm joined today by Dr. Alice Thompson, a specialist in neurological rehabilitation who works extensively with patients recovering from traumatic brain injuries, or TBI. Now, Dr. Thompson, TBI can have long-term effects that are difficult for patients to cope with. Could you tell us how patients tend to react when they begin to realize the full extent of these effects?
It varies greatly. For some patients, the severity of the injury is clear from the outset, so they're better prepared for what's to come. But others, particularly those with mild to moderate TBIs, might initially believe that their recovery will be quick. When the long-term effects, such as memory problems or mood changes, start to set in, it can be a real shock. One of my patients, we'll call him Mark, said it felt like losing control of his own mind. The frustration of not being able to remember basic things was overwhelming. He likened it to being trapped in his own body, but with someone else at the controls.
That sounds incredibly difficult. Memory issues are one of the most common long-term effects of TBI, aren't they? How do patients typically cope with these challenges?
Yes, memory loss is a very common issue, and it can affect day-to-day functioning. We work with patients to develop strategies to compensate for this. For example, we encourage the use of external memory aids like smartphones, calendars, and notes, which can help patients keep track of important information. Mark, for instance, found that setting reminders on his phone for even simple tasks helped him regain a sense of control. In more severe cases, we introduce cognitive rehabilitation exercises aimed at retraining the brain to improve memory function. It's a slow process, but many patients do see improvements over time.
Mood changes are another difficult symptom to manage after TBI. Could you explain why this happens and how you address it in your rehabilitation program?
Absolutely. Mood swings, irritability, and even depression are common after a TBI because the brain's emotional regulation centers are often affected. Patients can experience sudden emotional outbursts or feel depressed without understanding why. This was the case with another one of my patients, Sarah. She would go from being completely fine to intensely angry over small frustrations, and it was really hard for her to cope. We addressed this through a combination of therapy and medication. Cognitive behavioral therapy, CBT, is particularly effective because it helps patients recognize triggers and develop coping mechanisms. Medications like antidepressants may also be used when necessary to help stabilize mood.
And what about the physical aspects of rehabilitation? I imagine this is another key area where patients struggle.
Yes, physical rehabilitation is crucial, especially for patients with moderate to severe TBI. Depending on the injury, patients may experience balance problems, difficulty with coordination, or even paralysis. Physical therapy focuses on retraining the body, improving mobility, and rebuilding strength. We work closely with patients to set small, achievable goals, which helps them see progress and stay motivated. For example, Sarah initially had trouble with balance, so we started her on simple exercises like standing on one leg or walking on uneven surfaces. Over time, these exercises became more complex, and she's now regained much of her mobility.
That's amazing to hear. I've read that fatigue is another common issue for TBI patients. How do you help them manage that?
Fatigue is one of the most challenging symptoms because it's not just physical tiredness, it's also mental fatigue. Patients often find that even simple tasks like reading or holding a conversation can exhaust them. We work on energy management strategies, teaching patients how to pace themselves and prioritize activities that are most important to them. Rest periods are crucial, and we emphasize the importance of balancing activity with plenty of recovery time. We also look at lifestyle factors, such as sleep hygiene and diet, which can contribute to managing fatigue.
It sounds like managing the effects of TBI is a long and difficult journey for many patients. Is there any recent advancement in treatment that offers hope?
Yes, there's been significant progress in neuroplasticity research, which is the brain's ability to rewire itself. This has opened new doors in rehabilitation. We now incorporate techniques like transcranial magnetic stimulation (TMS) and virtual reality exercises to help stimulate brain function and encourage recovery. While these are still relatively new treatments, we've seen promising results. For instance, patients who've used virtual reality for balance training often report feeling more confident in their movements and experience. Fewer falls. The key is that the brain continues to adapt, even years after the injury, so recovery is possible, even in the long term.
That's encouraging to hear. And your research is ongoing, I assume?
Absolutely. We're always looking for new ways to improve patient outcomes. We continue to track how these new techniques work over time and are always refining our approaches based on what we learn. The most important thing is that patients remain hopeful and committed to their rehabilitation. With the right support and strategies, they can regain a lot of what they've lost.
Thank you, Dr. Thompson. It's been fascinating to learn about how TBI patients can overcome these challenges with the right care.
Extract 2. Questions 37 to 42. You hear Dr. Jordan Matthews giving a detailed presentation on dietary changes with diabetic patients. Now, read the questions. You now have 90 seconds to read questions.
Good afternoon, everyone. My name is Dr. Jordan Matthews, and I'm a clinical nutritionist here at the hospital. Today, I'll be addressing a topic that many healthcare providers find challenging, discussing dietary changes with diabetic patients. Dietary habits are deeply personal and can be influenced by culture, emotional needs, and lifelong preferences. As we all know, diabetes management often hinges on diet, but this can make the conversation particularly delicate. Many patients come into consultations already aware of the need to change their eating habits. However, like many aspects of health, knowing and doing are two entirely different things. Patients may feel overwhelmed, defeated, or even resistant to altering their diet, especially if it feels like a restriction rather than a positive lifestyle change. This is where our role as healthcare providers becomes crucial. We need to foster a conversation that feels empowering rather than limiting, one that allows the patient to take ownership of their health without feeling judged or deprived. One approach I've found particularly effective is starting the conversation by gauging where the patient stands. For example, asking, "How do you feel about your current eating habits in relation to your diabetes?" allows the patient to reflect and provides us with insight into their mindset. This question also avoids making assumptions, which is important in building trust. It's vital to remember that a patient's relationship with food is often tied to emotions and culture. For instance, when working with patients from different backgrounds, their traditional diets may not align with conventional diabetic meal plans. Instead of focusing solely on the clinical aspects of nutrition, we must be culturally sensitive and work within the framework of their preferences. This could mean modifying existing meals rather than completely eliminating them. During consultations, I try to avoid using terms like bad foods or restricted diets, as these can be demotivating and even trigger guilt or defensiveness in patients. Instead, I focus on terms like nutrient-dense or balanced meals to frame the conversation positively. It's essential to emphasize that the goal isn't to take away foods they love, but to find healthier ways to enjoy them. Another strategy I use is shifting the focus from restriction to addition. For example, instead of telling patients what they can't have, I suggest introducing more vegetables, whole grains, or lean proteins into their meals. This keeps the conversation positive and action-oriented, focusing on what can be added rather than taken away. Offering realistic alternatives like swapping white rice for quinoa or adding leafy greens to a favorite dish can make the dietary changes feel less daunting. Open-ended questions also play a critical role in guiding the conversation. Asking questions like, "What challenges have you faced when trying to make dietary changes?" gives the patient the opportunity to express their frustrations or concerns. This not only helps identify potential barriers, but also shows that you're genuinely interested in their experiences and are there to support them. When it comes to diabetes management, I often tie dietary changes to tangible health outcomes. For example, explaining how reducing sugar intake can help stabilize blood glucose levels and prevent long-term complications like neuropathy or cardiovascular issues can motivate patients to take action. By framing the conversation around improving quality of life rather than focusing solely on weight or restrictions, patients are more likely to feel empowered to make sustainable changes. Of course, not all consultations go smoothly. There are times when patients resist making any dietary changes despite knowing the risks. In such cases, I try to focus on incremental changes. Even small adjustments, like reducing portion sizes or cutting back on sugary drinks, can make a significant impact over time. It's important to celebrate these small victories with the patient, as they can serve as building blocks for larger, long-term changes. Providing ongoing support is another critical component of successful dietary management. This could include giving patients educational materials like meal planning guides or connecting them with a dietitian for follow-up support. I also encourage patients to involve their families in their dietary journey, as family support is often key to success, especially when shared meals are a part of daily life. In conclusion, the conversation about dietary changes with diabetic patients doesn't have to be one of restriction or limitation. By focusing on open-ended questions, cultural sensitivity, and incremental changes, we can help our patients make empowered choices about their diet that are sustainable and aligned with their overall health goals. Remember, our role isn't just to provide information, it's to motivate, support, and guide our patients in a way that fosters long-term success.
That is the end of Part C. You now have 2 minutes to check your answers.